Welcome to the Clinical Podcast Series brought to you by the American Academy of Optometry Foundation and the Anterior Segment Disease Care Channel. Today's topic, update on corneal dystrophies and genetic testing and therapy. Your host today is Thomas Quinn. The topical editor is Kelsy Steele, and today's topical expert is Susan Gromacki. Now, on to the show.
Welcome, you of curious minds, to the American Academy of Optometry Foundation's Clinical Podcast Series. In this episode, we will be discussing the identification and treatment of corneal dystrophies. I'm Dr. Tom Quinn. Our guest expert for this episode is Dr. Susan Gromacki, Director of the Contact Lens Service at First Sight Vision Care in Fulton, Maryland. Dr. Gromacki completed a residency in hospital-based optometry with the U.S. Department of Veteran Affairs, is in the leadership of the American Academy of Optometry Cornea Contact Lens and Refractive Technologies section, and has presented over 750 professional lectures and publications, many relating to today's topic, corneal dystrophies. Welcome, Dr. Gromacki.
Thank you, Dr. Quinn. I'm so happy to be here, and especially with you.
Oh, I feel the same way about you. It's a particular treat because you are, in my mind, one of the experts that we have at our disposal, and there's not that many when it comes to expertise in corneal dystrophies. So to ease us into this paper, which was published by Weiss et al. In the November 2022 issue of the journal Cornea, let's talk about, aside from using the slit lamp, what other tools can we utilize to help us properly identify corneal dystrophies?
Case history. Most corneal dystrophies are hereditary, usually autosomal dominant. So ask if there is a family history. Also, listen very closely to their symptoms. For example, in Fuchs dystrophy, vision is typically worse in the morning upon awakening.
Okay. Yeah, that's a great tip. And so this paper, it's a pretty heavy paper. I think you would agree. It gets into some weeds here, but they talk about gene therapy and how it's been successfully employed with some of the retinal conditions we've had out there, the inherited retinal dystrophies. What are some of the challenges that are being grappled with to employ gene therapy and detection and treatment of corneal dystrophies?
As Dr. Weiss wrote, the greatest barrier to developing gene therapy for corneal dystrophies has actually been our success with corneal transplantation. As a result, it hasn't made much sense to take on the risks or the costs associated with gene therapy.
Gotcha. So I want to talk more about the surgeries. Because that's evolved, right? Aside from the whole gene therapy issue, corneal surgery has changed a lot since I graduated. Can you talk more about how it's evolved?
Absolutely. Let's first talk about Fuchs dystrophy. That accounts for 39% of corneal transplantations. So if you look at about 15 years ago, penetrating keratoplasty, PKP, was the standard of care. That's a full thickness transplant. Over the years, this has progressed to DSEK, DSAEK, and now DMEK, Decimate membrane endothelial keratoplasty, which eliminates the stromal carrier.
Okay, so wait a minute. Can we stop? Go back up that alphabet soup there. So you and I may be somewhat familiar with what those mean, but can you break those down? Like DSEK, what is that? What's that mean?
Sure. So unlike the original PKP, which took the entire cornea away,
penetrating keratoplasty, right?
Transplant.
Yeah.
Basically, it's decimate stripping. So that's what the DS stands for. And the A in DSAEK is automated.
Okay.
Basically, same sort of thickness being removed there, just different procedure.
Okay.
And what that did was transplant less of the cornea, keeping more of the patient's cornea intact. And now with DMEK, we now have even eliminated the stromal carrier, so leaving just decimate membrane and the endothelium in Fuchs, the diseased tissue, left to transplant.
So basically the idea of today's surgeries allow us to go in and just remove the problem layer. So it's much less
Absolutely.
traumatic, right? So
Absolutely.
yeah.
And that is also the case with the surgeries for the anterior dystrophies, which would be a little bit different in that we remove almost all of the cornea, but leaving the endothelium intact.
Right, right. So that's, I imagine, takes a really skilled surgeon to do that.
Absolutely. Initially, the results were not quite as good as with PKP, just because of surgeon experience. But now that we've been doing these for quite some time, that is not a concern at all.
Okay. And what's it mean in terms of patient outcome? Now that we're doing these more sophisticated procedures, does it impact a patient in any way, in a positive or negative way? I assume there's a lot of positives.
Absolutely. So for the anterior transplantations, leaving the endothelium intact produces much less chance of rejection, and that's important for patients. And we certainly don't want to have to deal with treating a patient with steroids and possibly losing that transplant. So that's a big benefit.
Gotcha. Thank you for that information. That's great clinical information. Now let's come back to this paper that we're discussing. And I have a question for you. Is there anything we can take from this paper to help us when we get back in the lane with our next patient who has corneal dystrophy?
Well, it basically communicates to us that since gene therapy isn't yet the standard of care, to just continue doing what we're doing. So as optometrists, that means diagnose the dystrophy, treat recurrent corneal erosions if they happen, fit GP lenses for irregular astigmatism, and then when warranted, refer to a corneal surgeon for transplantation.
Great marching orders, Dr. Gromacki. Thank you so much for sharing your expertise with us today. And we'll look forward to talking with you all again next time on the
Sounds
American
great.
Academy of Optometry's clinical podcast series. Thank you, Susan.
Thank you.